Hi guys. So this week we're going to talk about intracranial regulation, so more or less strokes. Um, if you have questions, again, Robin is your go-to. I'm also available. I hope these are helpful for you. I'm sorry that it's a different background and if you can't see me very well. I can see myself pretty well, so I think we'll be okay. It's just really bright outside, but it's a nice day. So things that will clue you in on if your patient is having intracranial regulation that's like impaired. So things that will be different is mobility, sensory, cognition, and perfusion. So when they're not getting the correct blood supply to their brain or something's blocking it, then these things can go wrong. These patients have high morbidity and mortality. They either have life-changing alterations to their everyday life or they could possibly die. Early recognition is the key, and other things that can make it seem like your patient isn't having correct perfusion to their brain could be if they're not getting enough oxygen, if their sugars are high or low. You know, some people in different states of sugar are very confused. Ammonia levels can be, it can cause a patient to be really confused, infection, UTIs, and dehydration. So there's different parts of the brain that you should know that she will ask you about. She will give you like a patient had a stroke in their like temporal membrane or in the frontal lobe, and she'll ask like what deficits are there going to be. So just know frontal. I have it written down here. So frontal has personality, behavioral, intellectual function, voluntary movement, short-term memory, speech, and then it's called the Broca's area, and that is when you cannot speak. So she'll ask you, you should really know the Broca's area and then the Wernicke's. She'll ask you those two. So Broca's area is in the front lobe of your brain, and that's where you cannot verbally speak to someone. The parietal lobes up here is localized sensation, object recognition, body awareness, and image. The temporal is the emotion, long-term memory, olfactory, auditory, sensory, speech. And then the Wernicke's area is also in here, and that is where you cannot understand speech. So Broca's area is in the front. That's where you cannot speak. In the temporal, it's Wernicke's over here, and that's where you cannot understand speech. And then occipital is your visual input. So the occipital is pretty easy to me. I just think like your eyes go straight to the back of your head, kind of. She didn't really ask too much about like all your different cranial nerves and what they go with, like whether it's in your medulla or your pons, your midbrain. If you like section them out, there's like 2, 3, or 3, 3, 4, and 6. 1, 2, 3, 4, 5, 6. Yeah. So just look over those. She didn't ask too many questions about them, but understand them. I know there's a saying like, ooh, ooh, ooh. I can't remember it. You can look them up though. There's like different things you can look up to remember what they are and what they correspond with. But the main thing she'll probably ask you is where they're located in the brain, because if she says like your cerebral hemisphere didn't get enough oxygen or blood flow, what signs and symptoms could the patient be experiencing? And you could say like olfactory, optic, oculomotor, like things like that could be messed up or not correct. So looking at where they are in the brain will help you. So, okay, so a TIA, these are, we learned all about them in 4th, but in 5th, you'll talk about them too in Kelly's class. But TIAs are like a precursor to a stroke. So if they have a TIA, it's like a mini stroke. It's not going to be detrimental. It can be reversed. But it's if your grandma's like, I had one of my dizzy spells, or oh, it's just how Graham acts sometimes, like you should probably go get it looked at, because if you're having a lot of TIAs, you will probably have strokes. So a brief interruption of perfusion in the area of the brain. So it mimics a stroke. It can last for 30 to 60 minutes, but it can last longer, but usually they don't. If repeated TIAs to one area of the brain, then it can cause damage. So usually they're reversible, and they will gain all function back. But if you have constant decreased blood perfusion to one side of your brain or a certain area, then it can cause damage. They put TIAs put patients at a higher risk for ischemic strokes in the same area. It's considered a warning sign. Just like I said, go get it checked out. It's not permanent, but if you're having them, it can show perfusion problems. The carotid arteries are very important for plaque buildup. So if you're having a lot of plaque buildup here, you're going to have decreased perfusion to your brain, and they can have these mini TIAs as well. You can do MRI, CTs, ultrasounds of your carotid duplex, and surgery stents can be put in here to open it up. That way you can allow perfusion to get to your brain. So basically all the clinical manifestations of TIAs are the same as a stroke. So blurred vision, blindness in one or both eyes, tunnel vision, you can have weakness, face drooping, arms, legs can drift or kind of hang, numbness, vertigo, slurred speech. So just watch out for, the acronym FAST. Just watch out for all those signs and symptoms, because a TIA is pretty much like a mini stroke. Management of them. So you can do your NIH stroke scale. You can do the MRI, the CT, the carotid scans. The goal is to prevent another one and prevent a stroke, because they can lead to stroke. Decrease the blood pressure. Aspirins, other antiplatelets can impair the clotting. So if you think that it's because you have a clot or you have a history of clots and then they're getting very confused, sometimes they'll put them on aspirin or heparin. But also be prepared, because it disrupts all your clotting factors. So if they are having, if they fall and they break a hip, they're going to be more likely to bleed. Give them a soft toothbrush, all those things. Control your diabetes, because sugar can make you act this way as well. You want to make sure you know what you're dealing with before you start to treat it. Prevent other clots, and you can do diet and lifestyle modifications as well. So like you learned a couple months ago, AFib can cause clots. So if they have AFib, they should already be on an anticoagulant. But just remember that if they have AFib and they're kind of acting funny and you don't know what's going on, there could be a clot in their brain, and it could be causing a stroke. Help perfusion. So just it says I have here, could be increased of hypertensive state, and just like we said earlier, decrease the BP. So a stroke is the interruption of perfusion to any part of the brain. Medical emergency as a brain attack. So you have a heart attack, this is like a brain attack. So statistics is 14% of hospitalized patients will have a CVA while in the hospital. It's the third leading cause of death in the U.S. 1 American dies from a stroke every 4 minutes, and it's a major cause of disability. So just think, strokes are very serious to take. You have to take them very seriously. Just like a heart attack, a stroke is very detrimental. Immediate treatment is required to reduce injury and death. And then it just says down here, time is brain. So the more time you wait, the brain's not going to respond very well. Okay, so pathology, the brain needs persistent confusion. Oh my goodness. Consistent perfusion. Sorry, my dyslexia. I'm so tired. And O2, because O2 cannot, if your oxygen's not getting to your brain because perfusion's not getting to your brain, it's not looking good. So any disruption lasting over a few minutes. So if you don't have perfusion for a minute or two, like a TIA, it's reversible, but a stroke is serious. Just take it very seriously. Any disruption will be a lasting cause of brain death in tissue. Brain tissue no longer functions, leading to disabilities. Brain edema. So when you have swelling of the brain, fluid on the brain, it causes an increased intracranial pressure in the brain. It can cause confusion. So symptoms can appear in a contralateral or opposite side. So if I have a stroke on This is my right. I know I don't know if it's backward for you guys. This is my right. So if I have a stroke on my right side of my brain, the left side of my body is what's going to be affected. And if I have a stroke on my left side of my brain, my right side of the body is going to be affected. And that's because of your paths. You have crossways that happen in your medulla, and they go across like this, and they all kind of stack on top of each other. So if you have a stroke over here, it's going to affect this side of your body. Classifications of strokes. This is very important. So ischemic and hemorrhagic, those are the two. So ischemic is like a clot. It can be a traveling clot, plaque that just builds up. So you have a thrombolytic clot or an embolytic. Thrombolytic is just a clot that happens. Embolytic is like that traveling clot that came from a DVT. Then hemorrhagic, you can have an aneurysm, which is just the weakening of the walls, and it can burst, and then pooling of blood. You're just bleeding into your brain. You can have just malformation. So your arterial pressure in your veins, you know how you have like those capillaries and like things flow from one to the other? That can be very weak, and you can have malformations there, and that can burst. And then hypertension. So increased BP, vasoconstriction, anything that is happening in your brain that's not letting blood get through, but that's not a clot. It's like a perfusion issue. You're going to be hemorrhagically bleeding. Increased blood pressure is just more pressure, so you're just losing so much blood. So knowing which one it is tells you how you're going to treat it. So you cannot just give like, oh, they're having a stroke, give them heparin, because if it's a hemorrhagic stroke, they will bleed out even more, and you will kill them, and that's not what you want to do. So the best thing always to do is get a CT. CT. She does it for all the things. CT scan is the best to see if it's a hemorrhagic or a clot. Then once you get your CT, you know, I need to get this person heparin, or I need to stop the bleeding. So thrombolytic, so it's caused from usually plaque buildup in the carotid artery. So rupture of plaque. So I think we went over this before. If not, it's in this one. But when you have your artery and plaque builds up on the side of it and it bursts, your clotting factors continue to hit that really hard because it thinks that something that's supposed to be there has burst, and it really hasn't. It's just plaque that has dislodged. So the rupture of the plaque causes a clot formation. So you're just building up a clot over here, and it's going to extend to pretty much the whole artery. The clot formation is slow, gradual buildup. It is a slow onset. So your signs and symptoms will not be like right away. It will be a slow onset over minutes or hours. Often responsible for a TIA. So these people who have clots, who have carotid artery buildup, have a lot of TIAs, and then it's either going to dislodge and clot up there, or it's just not going to be able to get blood flow up, and that will cause your thrombolytic stroke. Often detected by carotid scans, or you can do your surgery. Yeah, you can have surgery to like clean out all the clot. Embolytic is caused by like it's breaking away, traveling to the brain. Think of like a DVT, AFib, things that are causing clots to go up in your brain. So break off, travels to the brain, usually comes from the heart, AFib, or it can be from like acute MIs, just anything that's going to really cause clots to travel is your main embolytic type. Clots become dislodged where the vessels narrow. So you have lots of big arteries leading to your brain to get all that perfusion, but the second that you start getting into the deeper part of your brain, the little capillaries get really thin and small. So the clot's going to go as far as it can and then wedge in there. Rapid neuro defects. So this is like, it's happening very quickly. You had a clot, it's traveling, you're fine. It lodges, you're not fine. Thrombolytic is slow, embolytic is fast. So CT scans, always check if it's a hemorrhagic or a clot. You need to know before you treat. Who's at risk for an ischemic stroke? She lists all these different kinds. It might have been like a select all that apply, and she'll give you ones that are obvious. So who's at risk for developing a clot? Just think, who's at risk for a clot? You have DVTs, hypertension, smoking, obesity, carotid artery disease. There's so many things that she had listed here. When you think who's at risk for an ischemic stroke, think who's at risk for a clot, and you should be able to just click, all of them. But just in case if she didn't give you the exact PowerPoint she gave me, there's that. So hemorrhagic stroke. So interruption of blood flow because of a vessel rupture. So vessels rupture when the weakening of the vessel wall, blood seeps into surrounding tissues and causes increased intracranial pressure. So there are 4 kinds. There's an intracranial hemorrhage, which blood vessels in your brain burst and you're just hemorrhaging in your brain and it has nowhere to go. Your skull is hard. So then you can have a subarachnoid hemorrhage. And then you can have an aneurysm or an arteriovenous malformation. So just know that there's 4. She really didn't ask too much about them, but just know the difference. Like intracranial is like uncontrolled hypertension. So it's just a lot of blood getting in there. Subarachnoid is the most common. It results from bleeding in the subarachnoid space due to rupture of an aneurysm. And then I know it's a little confusing. Subarachnoid and aneurysm are different, but subarachnoid can be caused by an aneurysm. So aneurysms are abnormally ballooning. So you'll have your vessel, and then you'll have this little like weird balloon on the outside because it's very thin. Sorry, the light doesn't like me. It's very thin, and then it'll burst. And then an AV malformation is very uncommon, but you'll have your artery and your vein and you have your capillaries and somehow there's a malformation. It just doesn't want to work with you. So those are the 4 common types of your hemorrhagic strokes. Risk factors can be genetics, smoking, illegal drug use, because illegal drug use, I don't know if I told you, drug use causes vasoconstriction. So when you are constricted or in increased hypertension, increased blood flow, it's going to be very tight. So yes, you want to vasoconstrict vessels when you're bleeding because you don't want them to bleed. But if you have too much of vasoconstriction and then an increased amount of pressure, like hypertension going through there, when it bursts, it's like a detrimental effect. So smoking, genetics, illegal drug use, hypertension, diabetes, high lipids, connective tissue disorder, so like thinning, like your tissues would get really thin and then they can't hold all the blood in there. Trauma, alcoholism, and some prescription meds like diet pills. You have a risk for stroke. So clinical manifestation. So this is what it's going to look like when you have a clot and when you have a bleed. So you're going to have, if you have a clot, it's like, oh, I have a little bit of a headache. I can't focus. My vision is disturbed. I'm confused. Sometimes you'll have like one side or both sides of your body won't work. Paralysis. You can like sometimes not be able to speak, and then minimal defects on the onset of stroke. So it's just not going to be like boom stroke. It's going to be like slowly increasing to that. A bleed, on the other hand, is like boom. If you have a bleed, you have the worst headache of your life. If they say I have the worst headache of my life, it's a hemorrhagic stroke. Get them to CT and get them to surgery. Like just it's very serious. So it's because they're losing all that blood with an increased cranial pressure. So symptoms can also be like muscle rigidity, decreased level of consciousness, nausea, vomiting, severe hypertension. If you have like droopy eye, ptosis, or abnormal pupils, you know how like you check your pupils. I know it's really weird I do this, but like when it's like reactive, when it's not reactive, it's very different. But clotting is a slower onset. They're still confused. They have like visual disturbances. That one is easier to treat because you give them heparin or you give them a clot busting agent and it'll break the clot up and then their symptoms should get better. Sometimes if it's a really bad stroke and they haven't had blood to that part of the brain for a while, you might still see issues. But if you have a bleed, you're just losing so much blood. Nothing's getting the correct perfusion. And that is like the worst headache of your life. All of a sudden, it's very like in your face. So assessment, take them to the stroke center. If you have a stroke center, if you have a stroke team, sometimes like your rapid is your stroke team, depending on the hospital that you're in, get help because it's very serious. And some people are like, oh, they're just confused because they're on an opioid or, and sometimes that's not right. Sometimes they're having a stroke. So evaluate the eligibility for fibrolytic therapy. So get a CT, see if it's a clot or see if they're hemorrhaging. If it's a clot, you need to start that fibrolytic therapy. There's like a certain time scale that you need to have things done by in order to prevent, or in order to like make the best of the situation or prevent like long-term issues. So determine if bleeding is taking place or if they're on an anticoagulant. If they're on an anticoagulant because they have maybe say you have an AFib patient, you think, oh, it produces clot, so it must be a clot. Maybe they're on an anticoagulant because they have AFib and that's what's causing them to bleed more. So it could be both ways. You really got to like think about it. Rapid stroke assessment protocol. After you determine the eligibility for what therapy, start the therapy. So identify what area of the brain is being involved, like what area, like if they can't see, then it's occipital. You know what I mean? Like see where if you get a CT, see where that clot is, see where the bleed is, see what's being not perfused right, and then go back and think, oh, okay, Maddie told me that this part, like the temporal part of the brain is emotion, long-term memory, smell. They can't understand speech. Okay, so if that's where my bleed or my clot is, those are the symptoms I should be seeing. If I'm not seeing those, maybe you have more than one area. Maybe it got lodged or it clotted in a certain area and it's not feeding different parts of the brain. Think about what you should be seeing and what you are seeing, and see where the issue is in the brain. What was the patient's activity when the stroke started? So were they raking leaves? Were they doing a lot of like heavy lifting? Or do they already have hypertension? Did they blow an aneurysm? Or were they just sitting at home? Were they in a car crash? Look at what they were doing, because that might tell you, oh, if this person was using a lot of effort and they already have hypertension, they so could have blown something and it might be hemorrhagic. Progression of the symptoms. So I have here, clots take time, bleeds happen fast. So just what I said, clots, you're going to see it, but it's going to be over time. Bleeds is going to be, this is the worst headache of my life and you need to help me now kind of stuff. So Glasgow Coma Scale, just know, she didn't really ask too many questions about like numbers, but just look over your scale. It should be 12 points total. There's 3 different sections. 15 and above is good. And we used to have this saying when we were in assessment, it was less than 8 intubate, but it's different for every patient, but the higher you are, the better. The lower you are, the worst. So stroke assessment, look at their medical history, look at their family history. Look if they have a headache, that's going to tell you a lot. Physical assessment, cognitive, motor, sensory, nerves, cardiovascular. Look at your whole assessment and see like were there signs that this was going to happen and how could I have stopped it and what can I do now to stop it. So sudden confusion, trouble speaking and understanding others, numbness, weakness, drooping, face, arm, legs, trouble seeing in one or both eyes, and then a severe headache. So cognitive changes, so there's a right and a left, and then it's responsible for, and then signs and symptoms. I kind of made a chart. So these are the 4 that she wants, and then I kind of made this kind of chart. I don't know if you can see it very well. But the right side is going to be visual awareness, spatial awareness, things like that. Left side is like language, math, critical thinking. So I know this is going to sound really weird. I have a twin. Her name is Riley. She was so much smarter than me in elementary school because we didn't know I had, I don't even know what it's called right now. Help me. Starts with a D. Sorry, you can't spell. Oh my gosh. Okay, anyway, I didn't know I had dyslexia. That's what it's called. Sorry, dyslexia. And so she was like so much better at language and math and all this the critical thinking, stuff like that. And I was really good at like spatial awareness, like envisioning things. So I was more the right-sided of the brain and Riley was more left-sided. So if you have a sibling and one of you is better than the other, it's like, think about it that way, because that's what helped me. So left side is language, math, critical thinking, like the smart. Not that right side isn't smart, but for all intents and purposes, play along. The left side is kind of like all that like school skill. The right side is like visual awareness, perception. So if you have something wrong with either of those sides, then the left, since you're smart on this side, you're not going to be as smart. So you're going to have like dyslexia or aphasia, difficult reading, math, stuff like that. So just think the left side, this is my left. So the left side is smart. So if something's wrong, you're not going to be able to read, write, math, stuff like that. The right side is more like spatial awareness, perception. So you're going to be disoriented, impulsive, and you're going to have poor judgment. So on the right side, I'm doing fine. And then all of a sudden I have a stroke on the right side of my brain. So I'm disoriented. I'm impulsive. I don't know what's going on. I'm very disoriented, poor judgment. I'm very smart on the left side of my brain. All of a sudden I have a stroke on the left side of my brain. So now I can't talk. I can't write. I can't speak. I can't do what I usually should have been able to do normally, like in school. So I hope that's helpful. But that's how I memorized it. Okay, so motor changes. So you can have hemiplasia, which is half, or hemiparesis, which is just weak. So one is you are paralyzed and you cannot move. The other side is just more weak. So just memorize those two. So symptoms are on the opposite side. If I had a stroke on my right side, my left side is showing signs and symptoms. If I had a stroke on my left side, my right side is showing signs and symptoms. Ataxia, which is like brainstem or cerebrum. When you have a stroke, you can't move. And the cerebrum is like where all your balance is. So if you have a stroke there, you're not going to have any balance. And then just think about this as hypertonia and hypotonia. So flaccid paralysis or spastic paralysis, they're just a little different. Shouldn't ask too many questions, but... Okay, so sensory changes, responds to touch and painful stimuli. So unilateral body neglect syndrome. So it's the right hemisphere. So for some reason, when the right hemisphere has a stroke, it ignores the whole left side of your body. And it's very dangerous. You need to keep safety is the biggest thing usually if you have a stroke, because they're not aware that this side of their body even exists anymore. So when they try to get up, they are only moving their right side because they had a stroke on their right side of the brain and their left side just doesn't know it's there anymore. So vision can also be an issue. Pupils can be like constricted or dilated. Ptosis, you can have like drooping. You can have different color. The conjunctiva, I didn't say that right. Briefed blindness. So just pay attention to the eyes, because when you have intracranial pressure that's abnormal, your pupils and your eyes are like a really good sign of what's happening. So when you do your cranial nerve assessment, chewing is, what's V? Is that 5? Chewing is 5. And then swallowing is 4 and 10. I don't know. I think V is 5 and those are 4 and 10, these ones. So you're going to want that. You're going to want, they're going to be, if they can't chew or swallow, they're going to be at risk for aspiration. They're going to need a swallow study. You're going to want suctioning by the bed. You're going to want to increase the height of the bed. That way they don't choke. You want thick liquids, and then you're going to get like speech therapy and like different kind of therapy in there to help them. Cardiovascular assessment, so they can have heart murmurs, dysrhythmias, hypertension. Keep their BP high, which I know sounds weird, but if they already had a stroke and they're not getting, okay, high as in like 150 over 100, not like 200 over, just not something super like high, but if they're already not getting perfusion and then you decrease their BP, it's not going to pump as effectively to their brain. So you want it a little bit high if they've already had a stroke. Decreased BP does not perfuse the brain, except maybe a clot. If you have like a clot up there, it's different, but just in general, keep their BP kind of high if they've had a stroke because they've already lost perfusion. So FAST, the acronym FAST, I mentioned it earlier. She has it in here if you don't know, but face, arm, speech, and time. So face, are you able to smile? So if you smile and only one side goes up and the other side doesn't, and this is a little droopy, that's a sign. Arms, if you can raise them straight, great. If you can't and one keeps like leaning or drifting, then you probably had a stroke. Speech, is my speech clear and articulate, or am I slurring my words and you can't understand me, but I think that you can't understand me? Time. So if you notice any of these, call 911, call someone to help you. If you're in the hospital, call for a rapid, call your stroke team, whatever it is that you call in your hospital, call them. So there's also another one, B FAST, and it's BE. So balance and eyes, and then face, arm, speech, time. So balance, if you notice someone limping or walking oddly and they usually don't, that's a sign. And then your eyes, like your pupils, like we talked about. So stroke alerts is a C handout. She might have given you a different handout, but it can be called with the code blue. Depending on the situation, there can be times for just a stroke alert, and maybe it's a different set of team that comes. All departments are in participation of a stroke care, so you have like testing that comes, like your CT people come, you have like nurses, physicians, speech therapy, a lot of people come. Record this event as if there were a code, because the faster that you start recording what's happening and when and how long it happened and how fast this happened and when this person started deteriorating, it's going to help them so much into figuring out what kind of stroke this is, how do we fix it, and how do we stop permanent damage. Diagnostic testing, so a non-contrast CT, if negative, ischemic origin. So it just shows like if the CT is negative and it's ischemic, it can be like the clot. You can see a clot in the CT. Just know a CT is what you want first. An MRI can show ischemic injury. A carotid Doppler can see that clot or plaque build up to see if you're not getting perfused. You can look at like cardiac ECGs or echocardiogram. Labs, you're going to want to look at all your clotting labs. You can look at elevated lipids, clotting studies, and cardiac enzymes. So goals of collaborative care. So maintain airway. So if your patient doesn't understand that they've had a stroke, put them on an MPO, get them thick liquids. Don't let them swallow anything that's like really thin. Sit the head of the bed up, have suctioning there. May need intubation. Sometimes patients don't understand what's happening and how they aren't at their best. So maintain airway. Assess level of consciousness using Glasgow Coma Scale. A CT to see if it's hemorrhagic or ischemic. Monitor and treat hypertension if it's above 180. So if it's above 180, it has in parentheses ischemic. So if it's above 180, it probably is ischemic, because if it were, oh no, sorry, that doesn't make sense. Monitor and treat hypertension if it's above 180. For ischemic. I was like, that doesn't make sense. So if you have ischemic and it's like a clot or plaque buildup where perfusion is not getting there, it's some type of blockage, and you have a high pressure, it could wedge the clot even further, and you don't want that. So for ischemic strokes, keep the blood pressure, if it's above 180, lower. Assess for increasing intracranial pressure. Prepare for, so if you think that it's a clot, prepare for fibrolytic medications. You can do mechanical, what is that word? Thrombolectomy, where they take out the clot, or surgeries. And then down here further, it has like nursing diagnosis, like inadequate perfusion or impaired swallowing. You know those. So improve cerebral function, or perfusion. So if it's fibrolytic and it's an IV non-dextrose isotonic, the time frame, just listen to the time frame. That's what's important. So time frame, if the onset symptoms, if the drug is available, is 3 to 4.5 hours. So if you think that your patient had a fibrolytic or if it's like a clot and you noticed it and it's been within 3 to 4.5 hours, you can use the clot busting like alteplase. That 3 to 4.5 alteplase, you can use that. If they're eligible for the criteria. If it's not, or if it's been past that, then up to 6 hours, you can deliver it directly into that clot. So if you do IV, you notice your patient had started changing, they got a CT, they have a clot, it's within 3 to 4.5 hours, use alteplase, you can give through the IV. if you noticed it, but they didn't get the CT and they didn't read it until 5 hours, as long as you're under that 6 hours, as long as you're within that 6 hours, you can give it straight into the clot. They do it their own way. They have these needles, whatever, but you can deliver the fibrolytic therapy into the thrombus within 6 hours of onset. If you're past that even, or if they're waiting to see what came back, you can remove the clot within 8 hours. So the best outcome, and it has to be within the criteria, if you give fibrolytic therapy like alteplase in the IV, it has to be 3 to 4.5 hours. If you give it after the 4.5, within 6, you can put it right into the clot, and within 8, you can take the clot out, and you should see improvement. You could also do like carotid carotid angioplasty and a stent to open up those arteries. That way you get your blood perfusion. So improving perfusion, hemorrhagic, stop the bleed. Sometimes they embolize an abnormal vessel or aneurysm. So if there's something that like blew or it's really close to blowing, sometimes they can put a stent in, sometimes they can't. It depends on where it's at. It depends on size, has it ruptured, location in the brain, age, all that stuff. So when you are looking at intracranial pressure, these are things you should be doing. So increase the head of the bed to above 30, give O2, that you want them in a midline position, avoid neck flexion, have a quiet area, vitals every 1 to 2 hours, BP range, space your nursing activities. Like if you can clump them here and clump them there and then space them out, that way the patient has more time to rest. You can do hypertonic fluids because when you have increased intracranial pressure, you want your fluids to go out of the cell and into the space. That way it can be drained, because if you do hypotonic and the fluid gets into the cell, it's just going to increase that size of the cell, and then you're going to have increased intracranial pressure even more. So I wrote these down from what she said in class. I'm not sure if you can see them. Okay, so complications. So you can get water on the brain, you can have vasospasms, you can rebleed or re-rupture, which is scary. Ongoing drug therapy. So just look at if they're on anticoagulants and antiplatelet stuff. Calcium channel blockers will decrease spasms in the vessel. So when you get to 5th semester, you'll see calcium channel blockers. When you get to the heart, in the heart, you'll give calcium channel blockers to stop vasospasms. So just if you know it now, it's even better. So even in like your vessels in your brain, if you give calcium channel blockers, it'll decrease the spasms. Stool softeners, because if you don't want them to like push really hard and strain themselves and then have intracranial pressure. Analgesics for pain, anxiety meds. These patients are beyond anxious, so give them those. Impaired swallowing, so avoid aspiration. I have this starred. So if they are gagging or if they have a cough reflex, then the nurse has to do a bedside swallow screen. If that is inconclusive, or if it shows that they can't swallow, then you need to contact the physician, and the physician will do their own testing and put them on like NPO or thick liquids or nectar thick or whatever. NPO, swallow study. Yeah. Okay. So adequate nutrition. So 50% of patients who have a stroke are malnourished within the 1 to 2 weeks post-stroke. So you put them on NPO because you don't want them to choke, but then they don't get the nutrition that they need. So sometimes you can put them on TPN. They can have a PEG tube. PEG is like in your tummy, because if you can't swallow, at least you're getting food into your tummy. Consult nutrition. So thick liquids, increase head of the bed, family nutrition, or family education for nutrition as well. Impaired mobility. So you're going to want to get them up and moving as quickly as you kind of can. You can consult physical therapy, begin physical therapy as soon as possible. Monitor for DVTs, support the limbs. If they have a droopy side or not droopy side, then it just depends. Maintain safety. Impaired speech. So if they can't speak, get them somehow to speak. Speak slowly when you talk to them. Slowly, and look at them. That way maybe they can read your mouth. do one command at a time, look at different interventions for communication, involve speech therapy. So look at their level of consciousness, look at their nerve, like how their loss of nerve innervation. They can normally regain control, but sometimes it might take a while. Look at intracranial pressure, safety, emotional support, rehab, stroke centers, whatever they need. Clinical manifestations of increased cranial pressure can be confusion, yawning, restlessness, headache, change in level of consciousness. Your eyes will look different, impaired motor, stuff like that. So the Cushing triad, this she'll ask questions about increased BP, decreased heart rate, decreased respirations. Kind of like if you were having, it's the opposite of, I can't think of it. Starts with an S. Opposite of, not a stroke. Come on. Starts with an S. I'm learning about it now. There's different kinds of it. I can't think of it. Okay. But shock. It's shock. Okay, sorry. It's kind of like the opposite of shock. Increased BP, decreased heart rate, decreased respirations. And then she'll also ask about this picture, or these here too. So if you have the decorticate or decerebrate, I can't say those words, but she has pictures, memorize those, she'll ask questions. And then you have a case study. So I will go over another PowerPoint as well, but this should help for stroke so far. If you have questions, just let me know. I hope this was helpful. Have a good day.